Good morning. I am your host, Facundo Batista. Together with Richard Young and Callum Overholt, we have organized this course on COVID-19, SARS-CoV-2, and the pandemic. On behalf of the three of us, thank you for joining today. The purpose of this course is to learn what we know about this virus and the pandemic from the best scientists across the world. And today, I am very proud to introduce you Dr. Amy Barczak. Amy has a professional dual life. As a medical doctor, he's an assistant physician in infectious disease at Massachusetts General Hospital, where she invests considerable amount of her time in treating and curing patients. As a scientist, Amy is an assistant professor of medicine at Harvard Medical School, and she runs her own independent laboratory at the Reagan Institute. Her laboratory focuses on studying strategic and basic and translational aspects of tuberculosis and pathogenesis, and more recently has been heavily involved in SARS-CoV-2. When the pandemic struck, Amy had a real busy time. She was at the front line treating patients at MGH, but also she applied her unique scientific expertise in high security pathogens containment to study SARS-CoV-2 and to support many of the needs of the scientific community in Boston. I remember talking to Amy at that time, and she will spend 2 weeks in the lab, and then she will quarantine for 2 other weeks before being able to come home after curing and treating patients. Amy had received her MD from Harvard Medical School, and she was distinguished during her medical school as a training of a Howard Hughes Medical Research Institute scholars focusing on tuberculosis research. She completed her internal medicine residence at Massachusetts General Hospital in infectious disease with an infectious disease fellowship at MGH-MGB combined program. And today she will here with us to share her views on COVID-19 and the pandemic. Amy, thank you so much for joining us today. We are very happy to host you here.
Thank you very much, Facundo. All right, and I will just share my screen. All right, and can everyone see that now? I will assume yes. Okay. All right, so thanks so much. It's great to be here. And as Facundo mentioned, I really have 2 roles. So I am a doctor, a clinical doctor, and attending in infectious diseases at Mass General Hospital. In there, I train infectious disease fellows, so the next generation of infectious disease doctors. And I see patients in the hospital on the inpatient wards. But I'm also a basic and translational scientist, and my lab here at the Reagan, as Facundo mentioned, studies basic TB for the most part. In the ways that we think in medicine and in the research lab are actually quite different. So in the hospital, our focus is really on the knowledge that we have. What do we know about this patient? What's the data we can gather? But that data is always necessarily incomplete. You can't know everything. You can't control every variable. So we learn to make recommendations and decisions in spite of that uncertainty. The research lab is really different. As opposed to focusing on what we know, we're always thinking about gaps. What are the knowledge gaps? What do I need to know to understand this process? What are the technological gaps? What are the things we need to develop to be able to solve this problem or answer this question? We strive for our data to be complete and well controlled, and getting to truth is really an iterative, self-correcting process. And so each speaker in this series has approached the topic of COVID through their own unique lens, and my unique lens is the perspective of the physician scientist. And so I'm going to talk to you about the evolution of COVID-19 knowledge gaps from the viewpoint of clinical medicine. And the goal is really not to give you a discrete set of information at the end of this, but to communicate the process of learning about emerging diseases from the perspective of a clinician. I will acknowledge the caveat that my perspectives reflect on clinical care of COVID patients in a large, high acuity, well-resourced city hospital in the US, where we were very lucky not to have to think about oxygen shortages or how to distribute care when there was a mismatch between patients and resources. There are a lot of issues about health equity and global health equity that as infectious disease doctors we think about. But my talk today is really focused on how we approach the individual patient sitting in front of us. All right, so I'm going to introduce a schema for thinking about emerging infectious diseases as a series of knowledge and technological gaps. So essentially when a new infection emerges, there is immediately a knowledge gap, right? What causes this disease? How does it cause disease? What's the pathophysiology? And once we learn a little bit about that, we then have a technology gap. How can we use that information to develop diagnostic tests, treatments, and vaccines? And, I think a lot of times from the basic science perspective, we then stop here and say, okay, we had our knowledge, we developed our vaccine, drug, antibodies, what have you. But in medicine, this really is the starting point for the next stage of the process, which is to identify and fill the next sets of knowledge gaps. So we have a new drug, who's going to benefit? How do we use it most effectively? We have a vaccine, how does this work in practice? And then beyond thinking about populations, how does each of these things actually apply to my individual patient? And I will acknowledge that although I've driven this as a linear process, I think as we talk through this today, you'll see that we are often cycling back through this. And I think you've heard from other speakers in this course that, we often, as doctors, compare the COVID pandemic to the HIV pandemic. And I think we can apply this schema to HIV as sort of a model for thinking about this. So HIV first appeared just as a series of unusual illnesses or syndromes in particular populations. A few years later, the etiology was identified to be the HIV virus. An important component of pathogenesis was found to be a decrease in this particular population of immune cells, CD4 T cells. In presentation, essentially the way patients came forward, we understood was infections, that we don't see in people who have healthy immune systems, and cancers. So once we understood that, we could move on to trying to fill this technology gap. And diagnostics came around a couple of years later. We had antibody testing and then the ability to test the load of the HIV virus, CD4 counts, so we could understand where people's immune systems were. And then drugs were developed. And so AZT was the first drug developed in 1987. And again, from a basic science perspective, okay, we've made it to a drug, but from a clinical perspective, when AZT was used alone, it clearly reduced viral load and prolonged patients' lives to some extent, but never to undetectable levels, and inevitably resistance emerged. And so that led to this understanding that we needed more medications, and we need to understand how to use medications together to effectively treat HIV. And so an entire consortium was formed to answer this and other questions about HIV care. And even once we understood sort of on a population level how best to deploy these medications, we still had to learn about the complications of each medication, which were the safest medications for pregnancy. What was the safest medication if someone had underlying heart, kidney, liver, or bone disease, for example? And so we've now gotten to the point, where we have really excellent diagnostics and medications for HIV, but it's taken us decades to get here. As we move into thinking about applying this schema to COVID, we can actually watch this progression happen almost in real time. And so I'm going to talk about knowledge gaps and really divide it into three eras of this COVID-19 epidemic. The early pandemic, and I will say this is mapped to the cases in Massachusetts from the Massachusetts COVID-19 dashboard, sort of into the early pandemic, mid-pandemic, and then now and beyond. And Facundo's referenced a little bit my introduction to COVID. So I was scheduled to start attending in the hospital April 1st, 2020. The first confirmed case of COVID in Boston was February 1st. I got a phone call, or actually it was an email from my clinical division asking me, if schools happened to be closed when I went on service August 1st, was that going to be a problem for me because I have young kids? And I have to say at the time, this seemed like a ludicrous proposal. I couldn't imagine schools being closed. But I was able to say, yes, we would have, childcare taken care of. At the very end of February, there was an international conference in Boston, which it turned out retrospectively we found was a source of a lot of spread of COVID in the Boston area. And then in mid-March, in fact, schools did close down. A few days later, Mass General announced that they would be shutting down all non-critical research. So the last part of March, I sent my lab staff home, finished out critical experiments, and prepared to start in the hospital. And I was in the hospital for the first 2 weeks of April, taking care of patients. So the night before starting on the ward, so essentially Mass General at that time had 4 general infectious disease consult services. And so all of us who were attendings on those services change on the same day. And so the night before we started, we had a late night Zoom call where those of us who were starting basically met with those who were just coming off service and met together with a senior colleague of ours who had trained in San Francisco very early in the HIV era. And, you know, they sort of shared their thoughts and wisdom and information about their experiences. And our senior colleague, again, shared some of the parallels between the early COVID era and the HIV era. In particular, you know, both of these diseases seem to hit disadvantaged populations particularly hard. There essentially were populations that were being targeted with hate crimes and hateful rhetoric. In the HIV era, this was the LGBTQ community. In the COVID era, this has, you know, been a problem for Asian communities. People who had the viruses were stigmatized when they came home. And I think on all of our minds, you know, the CDC made note of this in the US, and cases were coming out of Italy, or data coming out of Italy, suggesting that there was some rate of infection among healthcare providers. You know, and I think we all were aware that as infectious disease doctors, the risk to us is not the highest. We are not the nurses who are in the rooms day and night, and we are not the physicians who are putting in breathing tubes. But it was on our minds, what, you know, what are we potentially taking home to our families? So we concluded our call and got ready to go into the hospital the next day. And so essentially this is the context of my time on the ward. So this again is the Massachusetts COVID course, or a COVID dashboard. And so you can see I was attending during these times of the red boxes here, and it really was a time of exponential growth of cases in the hospitals, the first time of exponential growth of cases in the hospitals. And that is really what it felt like in the hospital. So in fact, because modelers had predicted that a surge was coming, the hospital had responded and had canceled non-emergent procedures, canceled non-emergent surgeries. And in fact, patients who did not have COVID were trying to avoid the hospitals because they were fearful. And so what that meant is that essentially entire floors of, you know, neurology patients, oncology patients, surgical patients had been cleared out and prepared to become temporary intensive care units. And so, you know, you would walk onto a floor one day, you know, sort of bright, shiny, and empty, with a staff waiting there to take care of patients. And over the course of that day into the next day, the entire floor would fill from left to right with, you know, COVID patients who were critically ill and needed ventilators, needed breathing tubes. So that was the time that I was attending. And by the end of the time I was attending, Mass General started sending out sort of daily updates about the number of patients in the hospital. And so at the end of my time, there were 312 COVID patients in the hospital, and over half of those were in intensive care beds. And so there was really an inflection point at how, as infectious disease doctors, we took care of patients. And we went from right before I came on service, every single COVID in the hospital was being seen by one of these teams, you know, but with 300 COVID patients, in addition to all of our other infectious disease patients, you know, essentially we could no longer follow every single one of these patients. And, you know, nor did we need to. A lot of what they needed was respiratory support. So we wound up following the sickest and the most complicated. And in fact, spent a lot of time going around. We were each assigned a set of ICUs, and we went around every day to ask questions about what they were seeing and carry back information that we were learning about these patients. Okay, and so, you know, what were we learning? So learning in clinical medicine really starts with textbooks and the medical literature, but it really ultimately is an apprenticeship. So you learn from more senior doctors about, you know, infectious diseases or whatever your specialty is. And, you know, as a discipline, essentially, we know medical knowledge, both individually and collectively, comes from this accumulated experience of seeing hundreds and thousands of cases of a particular disease. And I think especially as you know, in your first years as an attending doctor, you're always conscious that there are doctors out there who have 20 or 30 years more accumulated experience than you do. And what was really starkly different about this disease walking into the hospital is that there was very little accumulated knowledge, and there was a sense that we were learning as we went along. All right, so what was already known in this moment that I walked into the hospital? Well, we knew the virus that caused the disease. We understood how it infected human cells. We understood that lung inflammation was really important in causing severe disease. And we understood that people with certain pre-existing illnesses were at higher risk. And in fact, technology had also been developed. There was a PCR-based test for the disease. And yet there was so much we didn't know. And so in teaching you about some of these knowledge gaps and how we approach this, I will use case vignettes. These are not patients that I personally saw for reasons of patient confidentiality, but patients who were either described in the lay press or in the medical literature that really reflected the issues that we were struggling with. All right, so the first case was a healthy 49-year-old man. Early in March 2020, after going on a weekend ski trip, he developed fevers up to 103 and a lot of muscle aches. This progressed to include cough and chest tightness, and he saw his primary care doctor, who gave him a course of antibiotics for a possible pneumonia. This was really before it was appreciated that COVID had hit the East Coast. March 13th, he presented to the emergency room with a lot of difficulty breathing. Was put on a breathing machine and diagnosed with COVID-19. And over the following days, he received a series of different treatments, including hydroxychloroquine. He was enrolled in a trial of the antiviral remdesivir and was given an immunosuppressive and IL-6 cytokine blocking agent. But in spite of all of this, he continued to worsen. And so on the 18th, he underwent this maneuver called proning, where they take a patient and flip them from their lying on their backs to lying on their fronts, because it can help with oxygenation. You know, this is really the key to all of this, is trying to keep the oxygen levels in the blood high enough for the patient to be healthy, tissues to stay healthy. In spite of that, the patient continued to worsen and was put on something called ECMO. And so the function of your lungs, you know, as I think others have described, is to allow oxygen to exchange between the outside world and your blood. And when your lungs, even with the breathing tube, can't do that well enough, there is this last ditch procedure that can take the blood outside of your body, run it through a machine that oxygenates it, and then put it back into your body. And, you know, this is, you know, very high risk of having complications associated with it. But if you cannot oxygenate on your own, this is the one last thing that can be offered in a handful of cases. So this patient was very tenuous on ECMO for several days, but then ultimately at the very beginning of April started to get better, was able to come off of ECMO April 4th, and was taken off of the breathing machine on the 14th. And so I think this case, you know, illustrates, if you look at the individual points, some of the things that we had learned. Because we knew the virus, we had a diagnostic. You know, at this point in time, there was some equivocal evidence for hydroxychloroquine. This has since been proven not to be helpful. There was this promising drug that, at least in a, you know, tissue culture dish, could block viral replication. People had observed that IL-6 was elevated in severe disease, so it made sense to test an IL-6 blocker. And by this time, there was evidence that proning, flipping patients over, could help with oxygen levels. But, you know, as essentially each of these things illustrates, we were only starting to learn, and these new knowledge gaps were emerging. So a test existed, but it wasn't readily available. So in fact, this patient was only diagnosed, you know, a week and a half into his course of illness. The antiviral drug remdesivir had been repurposed, but we didn't yet know, you know, is it going to be effective in patients, and which patients are going to benefit? And so this knowledge wouldn't come out for sure until about 6 months after this patient was enrolled in the trial. Again, IL-6 blockers were used. They were previously existing, and we had seen in patients that IL-6 was elevated in severe cases of disease. But was this causative or was this correlative? And at that point, we didn't know. Was blocking IL-6 going to help? You know, if it did help, which patients specifically were going to be helped? And again, the answers to these questions wouldn't come out for another 6 months or so. I think one of the things that is most difficult, or was most difficult, I think both for providers and for patients at this point, is that we did not have an accumulated knowledge that could tell us how patients were going to do. So as a doctor, you really want to be able to tell patients and families, you want to give them a clear picture of what's the spectrum of possible outcomes. How might this go? What complications can happen along the way? And what's the likelihood of each of those things? And you're able to say that based on an accumulated experience, again, personal and collective. We had no experience to be able to communicate. And so these patients, these first patients, were really the foundation of building that knowledge. All right, case 2 is another illustration of how we were trying to find signal in the noise of all these patients. So a healthy, relatively healthy 85-year-old man had a previous heart attack, but was otherwise healthy and living at home. Developed muscle aches and cough, and then started feeling worse about 6 days after symptoms started and presented to the hospital. Was diagnosed with COVID, and as with many patients, his blood oxygen levels were quite low. Something that was striking and a little bit different about this patient was that his labs had really elevated markers of blood clotting. And so as a doctor, when you see that, you ask yourself, what do these elevated markers actually mean for this patient? Because it turns out that markers of blood clotting are somewhat nonspecific and oftentimes go up with inflammation and overlap with markers of inflammation. So you have to ask, does this mean this patient has a blood clot, or does it just mean that this patient is quite inflamed overall? And so this particular patient was ultimately found to have a large blood clot in a vessel that connects the heart to the lungs. And that was one of the reasons the patient had such low blood oxygen levels. So having identified this clot in this patient, we then step back and ask, if this patient has clots, is it something that's really specific to this patient that is independent of their COVID diagnosis? Or might other COVID patients have blood clots as well? Is this the signal of some new piece of knowledge that we should be thinking about? And so part of the learning we did was thinking about, how does COVID present? What are the complications that occur commonly, and what complications occur but much more rarely? And so, shortly after this particular case, this case was one of a series that were published in the literature that suggested that blood clots, here described as thrombosis or thromboembolism, was in fact a feature of COVID infection, in particular in patients with moderate and severe disease. And yet, even with that piece of knowledge that these patients, are at risk of blood clots and tend to get more blood clots, you then have to ask, well, what does that mean about how I manage all of my patients going forward? Would some of these patients or all of these patients benefit from blood thinners or anticoagulants? And, how do you answer that? You have to answer that either by case series or clinical trials. So, stepping back more generally, how do we accumulate clinical knowledge about a new disease that is presenting so rapidly? And these actually timelines here end in December of last year, but I think those of you who follow the medical literature know that there has been an incredible proliferation of COVID manuscripts and papers. So even by the time I was attending in April, these are papers estimated going up in orange here. So there were already thousands of COVID papers. And hundreds or thousands of preprints. And here on the left, essentially, you can see estimates of each of these things going up. The difference between papers and preprints is that papers have gone through a process of being rigorously critiqued and evaluated and improved by scientists and physicians in the field. So when those come out, it's a relatively final version of the knowledge within them, whereas preprints essentially have not yet gone through that rigorous evaluation process. It's a more unfinished version of the data. But both of these were really growing exponentially. In particular, preprints, you can see over the on the right here. And so, as you can imagine, it was hard or impossible to keep up with this incredible flood of papers and thinking about what it means for taking care of patients. We also learned that the peer review process, that process of rigorously evaluating papers, was not designed to help us take care of COVID patients, because it's not a rapid process. So there's in fact generally a long lag between a problem or question comes up in the clinic and when something can make it into a peer-reviewed publication. So there has been a move in particular for COVID toward these preprints or publication of data that has not yet been critically reviewed. It does allow for a much more rapid dissemination of this information, but it requires a higher level of critical thinking to consider, whether or not this is something you want to put into practice, because it has not been evaluated rigorously by peers yet. And so even as data was coming out quickly to help fill these knowledge gaps, finding the most relevant and high quality data was challenging. So clinically, the early pandemic was largely defined by trying to build a collective knowledge of the disease, including its presentations, complications, in the spectrum of clinical courses. So moving then into the mid-pandemic, and I consider that to be shortly after I was on service up until almost the present, the background had changed a little bit. So we had basic knowledge about the disease. We had basic knowledge about the clinical course. Highly sensitive and accurate tests are available. There's an antiviral drug, remdesivir, in clinical use, monoclonal antibodies in clinical use, immune modulating medications in clinical use, and vaccines have rolled out. And at the same time, there's been a lot of data that helps us understand how best to use these vaccines, diagnostics, and treatments. And so to some extent, we've moved into a phase of thinking about how do the data in these treatments inform my understanding in treatment of my patient. And so the reality is a lot of times our patients fall outside of the realms of what was studied in those clinical trials. So case 3, a 45-year-old man who had an underlying autoimmune disease that affected his lungs, and he was on a lot of immunosuppression even before COVID infection. Day 0, he was admitted with fever and was found to be COVID positive. So he received 5 days of the antiviral drug remdesivir and then more immunosuppression. Days 6 to 68, he was mostly at home, quarantined, but had 3 return presentations to the hospital where he got more immunosuppression because of difficulties breathing. And over this time, his SARS-CoV-2 level in his nose was slowly dropping. So it looked like he was gradually clearing his infection. But then on day 72, he represented with a very low blood oxygen level, and it was found that his viral load, SARS-CoV-2, was rising. So he was started on the antiviral drug remdesivir. His symptoms improved and his virus load came back down. On day 105, so we're now 3.5 months into his diagnosis, he came in with a bacterial skin infection, which can be a complication of immune suppressive drugs, was again noted to have low oxygen, which was attributed to his underlying lung disease, and he got more immune suppression. And then on day 128, he came back in with a rising SARS-CoV-2 viral load, given antivirals again, and his symptoms and the viral load resolved. But then day 143, he came back in with very low oxygen levels, had to be put on a breathing machine, had a rising SARS-CoV-2 viral load, and was diagnosed with a fungal infection at the same time. And in spite of receiving drugs for both of those things, unfortunately, went on to die. And so, I think this really illustrates this question, in a dramatic way. How does this diagnostic drug or vaccine actually apply to this patient sitting in front of me? And so for this patient, the care providers really struggle to understand at any given time point, is it the virus growing out of control or too much inflammation that's making the patient sick? And trying to distinguish that matters because they require opposing kinds of treatments. And so I think some of the challenges that we face in this realm, vaccines and drugs have not, or were not well studied, especially early on in immunocompromised patients. These are not the patients that get included in the initial trials. And so that, that patient, for example, that was treated many times with remdesivir, that was not how the drug was necessarily studied, but you have to use it to treat the patient because you don't have other options. Vaccines were not initially studied in pregnant women. And of course, it's incredibly clear now that this is a population that it's very important to vaccinate. And drugs are oftentimes not studied in individuals with liver or kidney dysfunction. And it turns out in COVID, if you have moderate or severe COVID, you often present with liver or kidney issues. And so knowing how to use these drugs in those patients is a challenge. So at the same time that we were struggling to figure out how to apply what we've learned to our patients, we've discovered that an evolving virus means that disease is also evolving. And so this case, a healthy 40-year-old man had received 2 doses of an mRNA vaccine, and in keeping with CDC guidelines, went about getting together with other vaccinated individuals, indoors and outdoors, unmasked. He lived in Provincetown, Massachusetts, and in early July attended a lot of indoor and outdoor social functions with many people there. A few days later, he developed cough and loss of a sense of taste and was diagnosed with COVID-19. He had an uncomplicated course and fully recovered. But essentially this started to change our thinking about what COVID looks like after vaccination. So this patient was part of a case series of 469 patients who were diagnosed with COVID in July in Provincetown as part of the large case cluster. And what was really remarkable about these cases is that this happened predominantly 75% in individuals who had been previously vaccinated. And so the thinking before this was that in the event that you were fully vaccinated, you weren't going to get symptomatic disease, even if you got infected, and you weren't going to be able to transmit. But this clearly was not the case with this cluster. And so why was that? It was because the virus was actually evolving to become more fit in the human population. So I think previous lectures have described for you viral replication. And so in the course of copying over its genome, viruses mutate, and those mutations, generally happen by chance, but any mutation that makes the virus more fit for a particular environment that it's in will hang around. And so the mutations accumulated in this particular version or flavor of the virus, the Delta variant, has made the virus slightly more fit for life in the human population. And so we think that that's because the Delta variant replicates to a higher level in infected patients. It turns out that vaccine elicited immunity is still very effective, in particular, preventing hospitalizations and death. But we do see higher rates of post-vaccination infection with the Delta variant. And if you look at essentially the different variants as they've been distributed in the population here of the US over time, you can see that by the time this outbreak happened in Provincetown, in fact, this Delta variant, which is more fit and seems to be more transmissible, had really taken over the population in the US. So in the clinic, these emerging variants have really pushed us to question what we thought we knew. And suddenly we're asking, well, these variants seem to cause more disease in vaccinated individuals, in particular the Delta variant, than what we understood before. So how well are our vaccines going to work against SARS-CoV-2 viral variants? If a patient presents with respiratory viral symptoms, how high should my suspicion for COVID be? And prior to that outbreak, physicians may have thought this is less likely to be COVID because this person is vaccinated, but in fact, clearly it was COVID. And then we still need to learn how is the clinical course of COVID in a fully vaccinated individual different or similar to COVID in an unvaccinated individual. And at the time that this case happened, we didn't yet know that, and that was knowledge to be gained. So clinically, the mid-pandemic has been defined by working to understand two things, really how to apply what we've learned and developed to individual patients, and then how new variants of the virus change what we think we know. So thinking now, sort of about now in the future, what are the ongoing gaps in knowledge and technology? So case 5, something that we really continue to grapple with, chronic complications of COVID infection. So this is a healthy 40-year-old woman who presented with fever, muscle aches, and a cough back before vaccines were available. She was diagnosed with COVID-19, had a mild course of initial illness, but since recovery a year ago has had chronic symptoms. And this has included severe fatigue, shortness of breath, and brain fog, which is difficulty concentrating and difficulty with memory. And when COVID-19 patients first started presenting with these symptoms after their infections had cleared, many of them were dismissed. These symptoms were dismissed. We now recognize this as the syndrome of long COVID. And so essentially these are symptoms here that come on, long after we've stopped being able to isolate virus. Oftentimes patients, some of whom were quite sick with COVID, some of whom were not sick with COVID, experience symptoms in a range of organ systems, including generalized fatigue, dyspnea or cough, problems with their thinking and headaches, and problems with their kidneys, for example. And so thinking about long COVID, we're really now back to the most fundamental knowledge gaps. So what is the pathophysiology of long COVID? Meaning, what causes it in your body? Which patients are going to be at highest risk of it? And, what is the course of their illness going to be? How long will it take for their symptoms to resolve or get better? And as of now, we don't know these things. Additionally, there's a technology gap. Right now, this is a syndromic diagnosis. You've had COVID and you have this constellation of symptoms, but there is no specific diagnostic and there's no specific curative treatments, only supportive treatments. And so this is an area of really active interest in the scientific field, and at the NIH. So centers for study are being established, but inevitably there will be a gap between study and the knowledge that can really improve patient care. Thinking out about what else comes next. As a microbiologist, I think about the way the virus evolves, and we've already seen that the virus has evolved a bit to adapt to the human population with the emergence of the Delta variant, and it's sort of child strains that are coming out of it now. But I think, the situation we find ourselves in, where we now have a mixed population of vaccinated and unvaccinated individuals, potentially raises an opportunity for evolution toward vaccine resistance. And that will, again, raise a whole new set of questions. How will these patients present? What will the disease severity be? How will we manage these patients? Do we need to build new technologies or retool our vaccines or other technologies that we have to be able to diagnose and manage this? And then I think finally, as a physician, I'm very aware that even with all of our advancements, mortality rates from COVID remain very high. So this is from the New York Times. As of yesterday, there were an estimated 1,226 people who died of COVID. It is important to note that severe disease and death are largely preventable with vaccines. But for those patients who present with severe COVID, all of our technologies and knowledge cannot necessarily save their lives. And I think we would all love to see this change. All right, and so in summary overall, hopefully I have given you some concept of how, as an infectious disease doctor, we think about learning and filling these knowledge and technology gaps over time. And I think our understanding of emerging diseases really goes through distinct phases. Initially, we have to build a basic knowledge that enables us to develop technologies like diagnostics. We need to build clinical knowledge that allows us to take care of patients and help our patients and their families understand what the course of the disease is likely to be like. We then need to use our basic knowledge to build technologies, diagnostics, therapies, and preventions like vaccines. And then there's a whole additional phase, learning how to apply these new technologies broadly and learning how to apply these technologies in very specific cases. All right, and with that, I'd just like to say thanks so much to Mass General ID Division faculty, fellows, and staff. This was a group of the attendings and fellows who were on service with me in April 2020. And I have to say, I cannot imagine a better group of people to be, essentially seeing patients in the pandemic with or working with on a daily basis in the hospital. I want to thank my lab and the BSL-3 core staff, who are incredibly patient with my chunks of time that I disappear into the hospital. And then the Reagan Institute leadership, who've really articulated and are implementing a vision of a research institute that brings together people who look like me, so people who do science and see patients, with very basic scientists and engineers to try to make concrete contributions to solving problems in human health. And with that, I am happy to take any questions.
Yeah, thank you so much, Amy. I mean, that was a wonderful talk of a part of a life that I knew very little about. So and I think that very nicely covered an aspect that we haven't touched during the course. So thank you so much for this. I mean, we have a couple of questions. I mean, one of them is, what was driven the choice of treatment in those early days with these patients? And essentially, we know that drugs need to pass through clinical trials and be approved for a particular, but obviously you show cases where people were treating with hydrochloroquine and so what was the rationale there? Can you tell us a little more about it?
Yeah, so I can tell you a bit about that. And there were sort of, I think, three things that probably guided that. So essentially very quickly, groups were coming together, including sort of national advisory groups, to really comb through the knowledge and make formal recommendations about what we should do for patients. And so as those guidelines came out, we started looking at those. So at that point in time, because hydroxychloroquine, there was maybe a little bit of data, that was something that was discussed as a possibility, at least in those guidelines. And so, that is sort of looking at those guidelines was important. I think the other thing that we did is like oftentimes our sickest patients, in the absence of any knowledge about what was going to help them, we would convene a panel of experts. So for example, for immunosuppression, back before we knew, is blocking IL-6 going to be helpful? Is blocking other things going to be helpful? Every single afternoon on service, we would get together with some of the people who study basically these immunosuppressive medications, rheumatologists and allergists and infectious disease doctors, and present our cases and say, this person is really sick, we've run out of options, can you help us think through whether an immunosuppressive medication might be helpful, and if so, which one? And so it was sort of a consensus of expert opinion. And then always going back to families and trying to make shared decisions with them and allow them to have input. We can't tell you for sure what this is going to do. This is what we feel like we have available. Does that sound like something you would be interested in? And so that's how that decision making happened. And then I think the other piece of it was trying to get patients enrolled in these clinical trials. So essentially, there's a drug out there, remdesivir, that maybe is going to be helpful. And if they get enrolled in the clinical trial, they might get the drug or they might get placebo. But if they get the drug, that might be their best chance. And we know this is the knowledge that we need to be able to make decisions 6 months from now. So I think that's really the three things, is sort of looking to guidelines, convening and talking with the experts, and then going back and talking to the families in particular, because these patients were too sick to participate, and then trying to enroll people in clinical trials that could ultimately get us the knowledge we needed.
And then you showed the graphs, about the early phase and the second waves. But obviously, during the first few days of the pandemic, there was very little access to testing. So how you put those numbers together in your mind in terms of how many people were infected in those days we never knew about? And
yeah, so essentially, if you think about my big graph in the Massachusetts COVID dashboard, it looks like there was like a little blip back in like April of 2020, this big blip last winter, and then a smaller blip more recently. And so the reality is, as you mentioned, back in April 2020, there was so few tests that essentially when people presented with COVID symptoms to their doctors, they were told, assume you have it, go home and quarantine. We can't test you. There's not enough tests. And so it was really only people that small chunk of people, small proportion of people, a large number of people who made it into the hospital that actually got those tests. And so, that little molehill in April 2020 was a tiny fraction of people who actually had COVID-19. And I think if you think about the graph of hospitalizations, that was a much higher blip, with smaller blips that came along later. And, those hospitalizations are sort of a proportional fraction of people who had COVID. So actual cases in April 2020 were much, much higher than what we knew or what we could record based on our diagnostic availability.
another question I got in here is, in your experience, do long COVID-like syndromes occurs with other viral disease, or this is a new era of this particular disease?
I would say I think this is a really good question, and I think this is something that we're still learning and understanding. So there are other, there are basically other syndromes with similar sets of symptoms, including I'm trying to remember the name of it, but there are other syndromes that essentially have been described. Chronic fatigue syndrome, right? That has a lot of really similar features. And essentially there is no etiology that has been identified for chronic fatigue, but something that's been raised as we've seen long COVID come out is, is it possible that people with chronic fatigue syndrome, in fact, had some, viral infection that was barely recognized a really long time ago, or maybe a series of different kinds of viral infections, basically are contributing to chronic fatigue. And so I think there are sort of these syndromic presentations that we don't understand well, that may in fact be related to sort of a post-viral syndrome. And I think long COVID is sort of opening the door to starting to ask those questions in on a basic pathophysiology level.
And Edward is asking, having worked through the pandemic as a clinician and scientist, is there a new policy you would recommend so can fare better against future pandemics?
Ooh, I think that is a big question.
Yes.
Better, maybe better directed at, somebody who manages policy, but I can say, I think some of the, I think some of the things that we've learned that, I will say, I think, again, different hospitals and different systems manage this in different ways. And I think it would be really nice to be able to take things that have been learned to work on a local level and try and implement them, on a state level or even on a federal level. So there's not so much difference in terms of, essentially the way individual places are responding, and everyone can have sort of the same coordinated response. But I think what was found to be really important was listening to the modelers. So essentially the reason that Mass General was never overwhelmed was because they were really listening to the modelers over at the School of Public Health and, other places in the world who were saying, look, there's no cases in Boston now, but this wave is coming. And so they shut down surgery and they shut down their, unnecessary procedures or procedures that weren't emergency procedures to open up those floors for COVID patients. And I think that mattered hugely for us. I would say on the basic science side, I think the other thing that has been, really important is sort of maintaining these capacities for rapidly learning about emerging diseases. So essentially having labs where you can quickly study emerging diseases, figure out how they're causing disease, so you can at least make it to a diagnosis or, to a diagnostic test relatively quickly. But yeah, I would say I think there's not a totally simple answer to that question.
I have a couple more questions, Emi, if you have time. Like, one question is, over the last few weeks, we have heard these two powerful drugs that seems to have a real effect. I mean, one from Pfizer, the other from Merck. As a doctor, would you recommend people not to get vaccinated because drugs are there, or what will be your recommendation there?
No, my recommendation is 100%, vaccines really are first line. If you are already infected, essentially you're relying on many things, being able to identify that you have the infection quickly enough to be able to make it to those drugs. And the reality is, so two things, as others have described for you, a lot of the worst symptoms of COVID in terms of people who go on to have really severe lung disease or require a breathing tube is not in that initial course of the virus, but later, in fact. And so if you're waiting for that drug to treat your viral infection, you may miss the window and you may actually go on to have more severe disease. So I think the drugs are a nice adjunct to vaccines for breakthrough infection, but they are not a replacement for vaccines at all. And the other thing I think I would say is that getting out of this pandemic essentially requires that we stop transmitting the virus to one another. And again, vaccination really cuts the rates of transmitting virus. So no, I would say I absolutely am a very strong proponent of vaccination for everyone who's eligible.
And with regards to long-term COVID syndrome treatments, I mean, are there any drugs out there? What is not? Because probably we are entering now into the phase that we were with the pandemic at the beginning, that is to understand, how we can treat this and the implications that this has socially, because it's a stigma and probably people in many cases do not believe,
No, that's exactly right. Yeah. So no, I think unfortunately, so there are essentially you can take medications that can help manage your individual symptoms, right? So we can give you medications to help manage chronic cough. We can give you medications to help manage, a feeling of heart palpitations. We can give you medications to help manage kidney disease. But all of those are sort of, not getting at the root cause of the problem. And so as of right now, because we don't understand what's driving, the root cause of all of these symptoms, there's not a medication that specifically addresses what's causing long COVID. It really is just about managing the symptoms.
And the last question is, HIV, for example, has other diseases that are associated. TB that you study is one, and other infectious. Is that the case for COVID-19, or is that much more prone to get flu or to get any other?
Yeah, so that's a really good question, and actually something that we asked a lot early on. So the types of infections that will sometimes come along with these respiratory infections, they are not, SARS-CoV-2 does not itself suppress your immune system, but it does sort of make your respiratory mucosa, so sort of your breathing system a little bit unhealthy. So there was a sort of a concern, could people get secondary bacterial infections in their lungs because of this? Or could they get, sort of secondary fungal infections in their lungs? And so our experience has been that actually SARS-CoV-2 itself does not seem to make you super likely to get bacterial pneumonias or bacterial fungal infections. But we do worry about people who require some of these immunosuppressive medications to help treat their COVID are then at somewhat higher risk for secondary bacterial or fungal infections. So not the infection itself, but sometimes our treatments make people more susceptible to other infections.
So, Amy, on behalf of the three of us and the students, thank you so much for a wonderful talk and really a unique perspective on what was going on during the early days, in particular as a clinician. And yeah, thank you so much also for the work that you do for the hospital, for the patients, and for all of us.